Hi there. Good afternoon, and thank you so much for braving the coronavirus to come out and gather. I thought I might have to offer free toilet paper or something to get people to come, since it might be the only way to get people places nowadays. So the other thing I will give you credit for bravery today is because we're going to talk about end-of-life issues. And we as a society don't do a good job of doing that. It seems like we just don't want to face the fact that we are mortal beings. Let's try it like that. If you think about when people talk about someone having died, when's the last time they actually told you they died? They usually have passed. And my response is always, I want to say, well, what did they pass? I guess they passed the final test, right? But or they passed away, or we lost them, and it's like, really? I mean, sure, that's a great euphemism, but the real truth is the person has died and their life has ended. I kind of like this slide. I just added to my talk, I think 1 or 2 talks ago, because it reminds us of that. But the truth is we don't get out of here alive. We all die. And dying is just as much a part of living as being born is. One of the differences is, though, you can control, to some extent, the conditions around which you die. And that's what we're going to talk about when we talk about advanced care planning and honoring choices. Can I have the next slide, please? So I just finished practicing as an internal medicine kidney specialist or a nephrologist here in Bellingham. Been here for 38 years. During that time, took care of a lot of really sick people, a lot of people both with end-stage renal disease, which is a disease that carries about a 25% per year mortality, and also critically ill people in the ICU. And I was truly moved and heartbroken by the number of times that I met with family members at their loved one's bedside when they were critically ill and truly had very little chance of living. And the question was, do we add yet another advanced medical intervention? And I would ask them, have you talked to your husband, wife, or parent about this? And they would say, we never had that conversation. One of the most glaring examples of that was a patient I took care of within the last couple of years, a man that was 83. At the age of 75, he had a heart attack and underwent bypass surgery, kind of a big deal. 3 years earlier, he required an aortic valve replacement, which was done transthoracically through the apex of the heart, which is called a TAVR, and had a severe leak, which required emergent surgery about a week later. And then over the next year, he developed a lymphatic cell leukemia, or lymphoma, actually, not leukemia, which produced abnormal proteins which damaged his kidneys, so a lot more serious problems. And then he developed kidney failure because of that, and came to dialysis unprepared for dialysis and required a tunnel dialysis catheter to undergo dialysis treatments. And within a week, he was hospitalized with overwhelming sepsis from the infection of the catheter. And he was delirious and in the ICU. And I asked, his wife came in, and I said, what would Tom like to do in this? And did you folks talk? He said, we never talked about that. And they had every chance. So the thing to do is we want to have our discussions long before that, right? So that is what got me started in presenting these talks about making your wishes known, which are your choices as you reach that point when you cannot speak for yourself, but also making those wishes, making those decisions within the realities what advanced medical interventions actually can provide for you. Get the next slide, please. I'd like to just give a little bit of history and thank yous to the people who got these talks rolling, the two individuals, Kathy McConaughey and Koala Conley, were two ICU nurses at St. Joe's. I worked with them for a couple decades. We shared the same sense of pain at seeing patients and families struggle with this. They decided to do something about it. And they put together a talk very similar to this about the realities of advanced medical interventions. And they originally presented it down at the Leopold. It was going to be a one-off talk, 20 people. And in the audience was Mickey Jackson, who's sitting in the back here today. And she heard their talk and said, you know, this is really important. And Mickey had just lost her husband, I think within the preceding year. And Bill Jackson, her husband, had done it the right way. He saw a couple years before he died what was happening and made clear decisions about how he would want that to go. And Mickey really knew the importance of getting this out. So she became the coordinator for this. They then went on to present about 48 presentations to about 3,000 people. About 3 years ago, I think they decided they had had enough and handed it off to Rebecca Cutler. She's a home health and hospice nurse with the VA, and myself, and we are now presenting the talks. And just recently, Alex Ray, who is a hospitalist for FCN, has joined us, and he will be doing an Hispanic presentation of the same information. So the idea is to just, this has grown to the point where we're really trying to commonly get the word out that these are important things. Can I have the next slide, please? So why are we here today? So I mentioned we're going to talk about wishes, that is advanced care planning and advanced directives, the medical care you want when you can't speak for yourself, and also designating who you will have speak for you, and the realities of advanced medical interventions, which are the things we need to know to put those wishes in perspective. Is this what I really want, in other words? So I'd like to kind of present this slide. Again, this drives home the point that we're not all on the same page with this. Many of us, 90% of people, believe that talking to their loved ones about end-of-life care is really important. 27% actually accomplish that. 80% say that if they were seriously ill, they would want to talk to their physician about their end-of-life care and their illness. And 7% actually do, a really an abysmally small percentage. And I'm going to have to say we physicians are going to have to take our part of that as well. 60% of people think that it's important to make sure their families aren't burdened with these decisions at the end, but only half of those people end up actually having that discussion with their family. And then finally, 82% of the population thinks that it's a good idea to put their wishes in writing. 23% actually do it. So that overwhelmingly, it's clear that we just don't do a good job of getting this done. And this number of 23 is very close to what we have in Whatcom County. I think it's about 25%, maybe 27% now. Have the next slide, Bill. Okay, first we're going to talk about, the first part of this is about the honoring choices. So we're going to talk about advanced care directives and POLST forms. We're going to talk about what they are, how are they different, what do they say, and who completes them. Okay. First off, this is the healthcare directive by Honoring Choices Pacific Northwest, and it is each of you has one in front of you, I believe. It is the advanced directive, which is most commonly used in Whatcom County. It's used with Peace Health and I think most of the other providers. It's a very good tool to sort of walk you through making these decisions and helping to set up a durable power of attorney. That is the person that will speak for you when you're not able to speak for yourself. And it's really good because it actually helps you go through it with that person, talking about what is valuable, how you value life, so that they know if you can't do those things, what decisions you would want done in that circumstance. Does that make sense? And then also there's the healthcare directive itself, which gives you a chance to express your wishes. Like most advanced directives, it provides a basic question if you would want resuscitation if you had a cardiac arrest. Would you want to stay on life support if you were not able to communicate and those sorts of things. And this is your wishes, okay? Next slide, please. But then there's also something called a pulse form. And this is it's a very different piece of information. Usually this is filled out by an individual who has a serious illness. And as a physician, one of the questions we would ask ourselves, if I found my patient, would not be surprised if this patient died in 2 years, they need to have a pulse form. So it's usually for people who have serious illnesses like malignancies, severe heart disease, lung disease, end-stage kidney disease, severe neurologic disorders. It's filled out by the patient or ideally with the patient, frankly, if the physician or provider can do it with them. They sign it and they carry it and it goes with them. It's a portable order for life-sustaining therapy, so it goes with that patient everywhere they go. If you sign it in the hospital, you go to a nursing home, it goes with you. When you take it home, it goes with you, and it's made this color so you can put it on your refrigerator, which I can tell you is where paramedics go to look for it. Just go ahead and change the next slide. I think it'll say something. Okay, so these are the key points of it. It is a specific set of medical orders that if you're seriously ill should be completed by you and signed by your physician. These are a physician's orders. So mention is kept with you. This is not an advanced directive. And the most important point is the bottom one, which is emergency medical personnel follow these orders. If you have a serious illness like stage 4 cancer, and you know that your life is coming to an end and you don't want to be resuscitated, if you just have an advanced directive and the paramedics are called to your house, they are going to resuscitate you because that is their job. If you have a pulse form, they will follow whatever is on that pulse form according to the way you want it. So that is a really important difference, and it's really important that we keep those two separate in that way, but also understand the importance of that. Sharm, you're an expert on pulse forms.
I'm kind of a plant, you guys.
Would you want to add anything to that?
No, it's a beautiful way to say it.
Okay.
Yeah, if you know you don't want to be resuscitated, one of these in the home will ensure that the medics can follow that direction, whereas an advanced directive is a legal form and it doesn't have a doctor's signature, so they can't. You can put on the pulse form that you do want to be resuscitated or that you want certain kinds of higher level care, and then your advanced directives can tell the doctors and the staff in the hospital how far to go with that.
Right. Okay,
So,
perfect. Thank you.
thank
Okay. So how do these two work together? This is a slide that I really like, which kind of puts all this in perspective in terms of honoring choices. First off, I think all adults, 18 years of age and older, should have an advanced directive. And you could say, really, do I, 25, 30 years old, some of you are probably 22, 18, healthy, why would I need a pulse form? And, I'm sorry, not a pulse form, an advanced directive. And I think for two reasons. One of them is the fact that you have an advanced directive means that you at least have thought about putting life in perspective, that I'm not going to live forever, that I am a mortal being and I'm going to live my life with that in perspective. The second thing is, I have personally experienced as a physician people as young as 20 with severe head injuries who were kept alive far beyond the point that I think that person would ever want to be. One in particular was a graduate from Western. He was 22 years old, celebrating his graduation. One of his buddies had a new motorcycle. He said, "Here, hold my beer, let me show you how to ride that thing." Went into a wall, had severe head injury. He was in the intensive care unit up at St. Luke's when that was an acute care hospital. Had a severe traumatic brain injury, never recovered. He ended up being intubated, trached. He was on dialysis for about 2 weeks, came off. He was in the hospital for 6 weeks, went to a nursing home, got pneumonia, came back to the hospital, went back and forth until finally at about 4 months out, they decided to withdraw care and not do anything further. He never regained consciousness, had no indications that he was alive. I think if I had that opportunity, I bet if he had his opportunity, he would have said, "I don't think that's what I want for myself." And that's why I personally think, and most people think, that it's a good idea for everyone 18 years of old. 18 years of age and older should have one. So once you get your advanced directive, it's not just set in stone. You really want to update that periodically. I was my parents' durable power of attorney for healthcare, and what I did was every Thanksgiving or Christmas or whenever I went to visit them, we'd sit down and say, okay, here we go, let's go over this again. If along the course of our life we either have a new serious diagnosis, advanced illness or frailty, meaning just advanced age, and we realize we're not doing as well as we did before, then we should have a pulse form using the criteria I mentioned before. And the pulse form can be updated. An example I've used before is that, let's say, at my age, not terribly young anymore, I developed a malignant lymphoma. And it can certainly happen. And I was diagnosed, and he sat down with the oncologist, and he says, you know, we could do monthly CHOP or chemotherapy cycles, and you've got at least a 50% chance of surviving this 5 years or more. And you say, okay, I'll do that, but I think I'm going to go ahead and fill out a pulse form anyhow, because I want to have down pretty clear parameters what I'm willing to do and not do. Analysis goes along, let's say a year later I'm disease-free and have no evidence of malignancy, I'm doing great, then I might change my pulse form. But let's say at 6 months, I've had 6 rounds of chemotherapy, I haven't tolerated it well at all, and the disease progresses. I'm going to update my pulse form, and it's going to be a lot different than it was before. I'm going to put it in perspective the fact that I'm failing curative therapy, and I'm really going to look more at being comfortable. So that's why it's important to remember that none of these things are set in stone. They always need to be updated as our life changes. And if we go down this route, hopefully our treatment wishes at our end of life will be honored. Okay, Bill. Okay, so when should we make these decisions? Hopefully we make them before we reach this state, the people I sort of talked about before, who are unable to speak for themselves. And again, it always seems like it's too soon until it's too late. This is a thing you can always do later. I'll always do it later. We'll do it later. We'll talk about that next year. We'll talk about that later. And it never comes next time. So now we're going to talk about, so that was just a brief introduction to advanced directives and pulse forms. On Thursday, Dr. Chow is going to do a presentation on advanced directives and actually walk you through completing one. It's a really good course. It takes about an hour and a half. Mm-hmm. And when you're done, you know exactly what you probably should know what you want to have on it. So now we've introduced those, now we're going to talk about, okay, now let's put this in perspective. What are the medical interventions I need to think about when I'm making my decisions? So these are the things that I consider important. There certainly can be others. There's the first thing that comes up on every advanced directive and pulse form is, do you want CPR if you have a cardiac arrest, or do you want to be allowed to die a natural death in that circumstance? And it's interesting, invariably comes up also, is a lot of people don't know the difference between a cardiac arrest and a heart attack. Does everyone here know the difference? The people that have been through nursing probably know that already, but is anyone clear that they are not the same?
Could you explain?
We're going to explain it, okay. And then we'll talk about intubation and mechanical ventilation, pressure drugs to support blood pressure in the case of shock, circulatory assist devices for severe heart failure, dialysis for kidney replacement therapy, artificial nutrition, including tube feedings, and then palliative care and comfort care. Okay, so this is the top portion of the pulse form. I kind of use this as a guide through my slides because it kind of breaks things down, I guess, the way I think about it. But this is what it looks like. And the first line is cardiopulmonary resuscitation. If you are found with no pulse and no breathing, and therefore you have a cardiac arrest, do you want to attempt resuscitation or not attempt resuscitation? Okay, differences between cardiac arrest and a heart attack. A cardiac arrest is an electrical problem with the heart where it no longer is pumping in a synchronous manner that allows it to pump blood in a adequate way. Typically it's caused by ventricular fibrillation, the most common cause, which is truly a fibrillation, a sort of squirming of the muscle which has no ability to pump blood. And there are others, well, probably the most difficult one is when the heart just completely stops in something called asystole, because that's very difficult to restart. And a heart attack is a block of an artery manifested mostly by chest pain. Go to the next slide, Bill. So this is a heart attack. You can see the heart muscle here is being damaged because one of the arteries is occluded and not getting an adequate blood supply here. This causes chest pain. You're awake, you might be in a fair amount of pain, maybe short of breath, but this causes pain. Most often is caused by a blocked coronary artery. And the treatment for this is to get that artery open as soon as possible. Nowadays, if you present to the emergency room and they think you're having a heart attack, and usually there's some very quick ways to find out, you'll go directly from the ER. You basically don't even stop there. You get checked in and you go right up to the cath lab so that the artery can be rapidly opened. In the meantime, there's some medications that will help somewhat, but really until that artery is open, that muscle is starting to die. And it will reach a point, if it's long enough, where that muscle will no longer function after that. Next slide, Bill. So cardiac arrest, entirely different. The person loses consciousness, passes out, and is not breathing. Excellent. This occurs, okay, we mentioned that. The most common causes, it turns out, is coronary artery disease, and it can be caused by a heart attack, but heart attacks make up only a small portion of cardiac arrests. Cardiac arrests are caused by severe heart failure with dilated cardiomyopathies, for example, electrolyte disorders, electrical shock, or drug overdoses, for example, can cause a cardiac arrest without actually having any problems with coronary artery disease. The treatment for this is CPR, immediately started, and the most important element of this is availability of an automatic external defibrillator, an AED, which is then used to shock the rhythm back to normal. Next slide, please. How common are cardiac arrests? Well, it turns out cardiac arrests out of the hospital occur about 350,000 times a year in the United States. In-hospital cardiac arrests account for another 200,000, for something in the neighborhood of 550,000. We're only 4% of the world's population. If you look at it all, it's about 3 million people a year in the world die of cardiac arrest. Next slide, please. So how common is it as a cause of death? This just shows you the comparison of breast cancer deaths versus cardiac arrest deaths. You know, I think cancer is such a dramatic illness. It kind of is somewhat overshadows some of the other things which are actually much more common, because these, frankly, cardiac arrests happen and it's over now if you don't get resuscitated. Next slide. This is another example of how cardiac arrest accounts for 50% of this other accumulation of causes of death, including Alzheimer's, breast cancer, colon cancer, diabetes, HIV, and motor vehicles, and suicide. So again, it's a very common cause of death. Other important facts to remember: 80% of the time this occurs at home. 80% of the out-of-hospital arrests occur at home. 20% of the out-of-hospital arrests actually occur in public places, like here. There's a 10% decrease in survival for every minute that passes that CPR is not initiated. In 10 minutes, the game is over. The average response time for paramedics to arrive is 8 minutes. You know that that's an average. I mean, if you live out in the county, it's going to be a lot longer than 8 minutes, so it's important that CPR be started long before that. How is CPR performed? Again, I think any of you in the medical field are pretty familiar with this. Try to keep this pretty straightforward and simple. It simply is using the palms of both hands on the sternum to compress the heart between the sternum and truly the vertebral bodies of the thoracic spine. You're compressing the heart, and as you compress it, the chambers squeeze the blood out just the way your heart would do it if it was functioning normally. You do it to a rate of about 100 beats a minute, or I think it goes to the tune of staying alive, according to the old Bee Gees, huh? And with decompression, the heart refills again, and then you compress it to pump the blood into the circulation again. Okay. Sometimes emergency responders have a device to help them called the Lucas device. This is a pretty impressive device when you see it in person. Has any of you ever seen this on someone? It's kind of a violent looking device, because that thing is doing the work of a 200-pound paramedic. But the advantage is they can put it on the person when there's only 2 responders, and the other person can intubate the patient, start an IV, and do the things they need to do to try to resuscitate them and still not lose CPR, where every minute you stop that, you're losing brain cells and losing chances of survival.
Plus it doesn't get tired.
Pardon me?
Plus it doesn't get tired.
Right, that's right, that's right. Good point, very good point. And as violent as it is, it actually does not, in the most recent study I saw, did not have a higher association with rib fractures and all the other complications of CPR. They all still occur. Okay, Bill, thanks. And the next most important, this is the most important thing you could do. If someone had a cardiac arrest right now in this room and there was an AED in the hall, that would be their best chance of survival. These are really straightforward, simple devices. All you have to do is expose the chest, put the pads on, and the machine tells you what to do. We'll turn it on and it tells you what to do. You don't have to interpret rhythms. You don't have to say, I wonder if this is the right thing. It just says shock, and that's what you do. This is a chart showing the survival rates of cardiac arrest patients. This is the average of all patients, 7%. If they only have CPR, it's about 8% or 9%. If they have a shot, if they have a automatic external defibrillator or are defibrillated, it's closer to 35%. Okay. This is another example of the chances of survival from a cardiac arrest, and these are minutes to defibrillation. And you can see it just dropping precipitously until the person can be defibrillated. So even if you recover, things are not always as you'd like them to be. There's also a significant chance of having neurologic injury because of the period of time when blood was not adequately circulating. And this just shows how important age is in that regard. Now these are proportionate, and none of these numbers are great, but you can see that this is for individuals under 70 in this particular study, which was from about 10 years ago in the journal Circulation. Is up here, and for the people over the age 85 and older, it's less than half of that. So it's important for people to take that into account when we're talking about, is CPR the right thing for me? And that's what this whole discussion is about in terms of how important it is in terms of timing, where it occurs, and how futile it is if you don't get good CPR and get a shock. Just so you can put in perspective, these are the things we need to think about when we say, sure, I want CPR. Because if it happens 10 minutes late, it's not going to work. If it happens 5 minutes late, it might work, but then you might be having a significant neurologic deficit to deal with afterwards. Next slide, Bill. And CPR it comes with a cost. I mean, typically, as I said, if it's not the Lucas device, it's some very big, strong paramedic pushing on your chest. And oftentimes results in a fracture of the ribs or sternum. If they're using a bag to inflate the lungs, oftentimes there's also distension of the stomach, which can result in aspiration of stomach contents. If you break a rib and it happens to injure the lung, you can get a pneumothorax or collapsed lung. There are particularly older individuals with severe cervical arthritis, when their head is tipped back and an attempt is made to intubate them, they can have cervical spine injuries. And if you puncture the sternum or break the sternum and it cuts into the pericardium, the lining around the heart, you can actually bleed into that, which then creates cardiac tamponade and another very difficult situation. Or if you lacerate the liver with a xiphoid, then you also end up with intra-abdominal hemorrhage. How often do these occur? It's very much age dependent. Young, healthy people, like many of the folks in here, are going to, their rib cage and sternum are going to move very easily. Probably even at my age, it's not going to, my age, I should say, it's way past being good, but anyhow, it's not going to go so well. So again, these are just the things we take into consideration. Actually, a good example is one of our dialysis patients had a cardiac arrest on dialysis, and the nurses are all trained in CPR and advanced cardiac life support. They rapidly got on the floor, did CPR. They have an AED, the defibrillator within a minute. And she came back. She ended up in the hospital in the ICU on a ventilator because it turned out she broke all her ribs. And she was never able to get off the ventilator and ended up withdrawing life support 2 weeks later. Another, again, example of even when in the best of circumstances and things are done right, things can happen that make it not the right thing to do. Next slide, please, Bill. Okay, so these are sort of, how do we survive CPR? Well, where you are counts. If you're in the ICU being monitored, best chance in the world that things are going to go okay, except you're probably in the ICU for a reason, and that's when you look at ICU data, it's not as good as you think it should be, but that's because these people are sick. Being in the hospital, if it turns out if you're in a hospital bed on the 4th floor at St. Joe's, unmonitored, you might as well be at home if it's 4 o'clock in the morning, because no one's going to know anything happened for the critical 10 minutes when CPR should be done, but that's just the way things are. If you're at home by yourself, not so good. If you're at home and you have someone there that can initiate CPR and call 911, maybe not so bad. So again, the second point is who's there counts. It makes a big difference. How close the first responders are with an AED. There are some cities, and I think Seattle is getting close to the point where they have AEDs on almost every corner downtown too, and they actually have one of the higher out-of-hospital survival rates. What medical conditions you have is critically important in terms of whether or not you survive CPR. There are pretty good studies that look at individuals with advanced malignancies who say they want to be resuscitated and they get CPR and they just don't tend to do well at all. Likewise, like the patient I told you, the very frail woman that was on dialysis and the ribs broke because of the metabolic bone disease from her kidney failure, didn't do well. So it very much depends upon whether the medical conditions are present. And again, how old you are depends upon how many complications you're likely to have and whether or not you have neurologic injury. So again, CPR, right place, right time, right thing to do. As we get older and accrue medical problems, may not be in our best interest to think it's a good thing. Okay, next slide, Bill. So the next section of the pulse form has a spectrum of things we can do, going from full treatment to selective treatment to comfort-focused treatment. And full treatment means you go in for everything. Selective is basically somewhere in between that and comfort care, which is down here. And we'll talk about all those. So first off, this is a little bit like what full treatment can look like. This is an ICU patient that's on continuous dialysis. They have a IntraAortic balloon pump in, they're on a ventilator, and they have, as you can see, multiple drips and pumps of different medications going. One of the things about full treatment, and when people say, I want everything done, you suddenly bring in a whole bunch of now specialists, and everyone has their own focus of what your care should be. And it's kind of like getting on a train that doesn't stop at every station. It just starts going And then everything that comes along, the person says, oh yeah, relative to this, say we just need to give him some more blood, or oh, okay, well, he just has a little intestinal bleeding, we'll do an endoscope and we'll take care of that. Or oh, it looks like his portion of his small bowel's dead, so we're just gonna go in and cut that out. And you just keep going, oh, now he has kidney failure, so we'll just do some dialysis for a while and I'm sure he'll get better. And meantime, they're on a ventilator, now they're trached, and things are just deteriorating one thing after another. So when people ask for full treatment, it's very hard sometimes to stop that momentum. And that's one of the things that I think I'd like everyone to kind of keep that in mind. And even as caregivers, what you want to do is be able to step back and say, are we doing the right thing here? You know, it's always appropriate to say, is this the right thing for this person? Does that make sense to you guys? Okay. Next slide. So next, we'll talk about intubation and mechanical ventilation. This is, most of you I suspect are familiar with this. Endotracheal intubation is when an endotracheal tube is placed over the back of the tongue, through the pharynx, behind the epiglottis, and then into the trachea. And it has a little balloon there, which is inflated by putting air into this device. And that creates somewhat of an air or liquid tight connection so that secretions from your mouth don't continue down into your lung, because now your airway is completely unprotected. You cannot keep things from going down that way. Next slide, Bill. And this is what the mechanical ventilation setup looks like. Air is coming in one direction after it's been humidified, and it then comes out again and is filtered and goes out to the atmosphere. And there's a device that measures the pressure and volume of the breaths that are being given to the patient. A couple things about mechanical ventilation and intubation. First off, a nasogastric tube is always necessary. That is because you have to go down to keep the stomach empty, so when the patient's laying down, stomach secretions don't come up the esophagus and then go back in to cause an aspiration pneumonia. Another thing is, obviously the patient can't speak, makes communication difficult. And if you had that tube in your mouth, what do you think you would want, the first thing you would do when you woke up you'd want to do? Yeah, so you want that thing out of there. So restraints are usually necessary. Next slide, Bill. This is again an example of a guy in the ICU who is on a mechanical ventilator. Most of the time they're kept up at about 30 degrees to prevent aspiration of gastric contents. He's got a nasogastric tube, he's restrained. It is what it is. These are the things we have to do for some individuals to get them better. Next slide, Bill. So these are some of the consequences of mechanical ventilation. Delirium is usually associated with the disease that has caused the person to be intubated. They do require restraints because of that. They're not able to communicate. Occasionally individuals are with it enough that they can actually write on a tablet. There is a possibility of lung damage, vocal cord damage, or tracheal damage from that little balloon we said blowing up, because especially if the patient's moving around a lot, that can go back and forth and sort of erode and create ulcerations in the trachea. And then if they can't get off the ventilator, if you can imagine, if you're on a ventilator and the ventilator's doing all the muscle work for your chest wall and your breathing for 10 days or 2 weeks, those muscles don't work very well anymore. They become atrophic. And then you actually sometimes can't be weaned from the ventilator, and they require tracheotomy, which is this little device inserted into the trachea over here. And if the patient is otherwise improving and is able to be discharged, there are no places locally where long-term ventilation and tracheotomy care can be given, so they have to be transported to a long-term acute care facility in Seattle. So that's mechanical ventilation. Ma'am?
Are you taking questions?
Yeah, I'm sorry.
No,
Ask questions as they come up, please. I'd rather have...
I'm not really sure what I'm asking here. So it could be the case that in the not the directive, but what is it called? The
Pulse form?
Someone puts the third thing down there, which was comfort care,
right.
comfort treatment.
Mm-hmm.
But let's say there's someone who is in an accident, doesn't have underlying medical conditions, and it's severe enough, but the prognosis is that there'll be recovery to the point where there would be quality of life. But if you put no, only comfort, then are you then discounting any intervention to help with the recovery?
If you have a pulse form, it means you have a pretty serious underlying medical condition.
Oh,
Right?
so
The pulse form is for people that have, that's the form that if I'm a physician and you came to see me and you had a disease, that I would say I wouldn't be surprised if you didn't make it 2 years, you would have that. So it's unlikely if you're in that severe an accident that you're going to do well anyhow. Does that make sense?
However,
But I know those directives are given.
I think if people are underlying, if there's underlying, you're healthy going into it, there's an assumption that at least initially, you'd want us to do those life-saving things. The 911 gets there, and then in the hospital, it gets determined,
Right.
you know, what your chances are kind of down the road. And that's where your advanced directives are really important, because the doctors in the hospital can say, oh, this is someone who said I'd never want to be on long-term ventilation, or whatever. Is that?
And these things are discussed freely in the hospital. I mean, we would have sit down with you or whoever, your loved one in that circumstance, for example, and say, you know, this is a circumstance, is this what you think they'd want to do? And even if their pulse form said that, if you're the durable power of attorney, you still have the right to adjust what their care is. Right?
We'll discuss that in when we go through the advanced directive on Thursday. We'll go through the various scenarios and discuss that.
A couple of comments. I haven't heard a lot of, you mentioned it a few times, but nothing directly in terms of the durable power of attorney. And I'm an attorney. I practice out in the San Juan Islands. We have a couple of unique issues, but one thing that I've learned through my legal classes with doctors talking, but rather hear it straight from the doctors at an event like this, is that it's almost more important to appointing a person that knows you and your values while you're healthy, because you can't plan for all these, you know, little pulsed things. But you want someone that knows your general attitude about life, whether you've had a good run or you want to wring out every moment of life you possibly can. And then let them make the decisions and they can actually fill out a pulse, which is kind of weird from a legal standpoint, on your behalf. The other thing, in the rural area, because the EMTs want to see it pulsed, I went to a workshop where they were saying everyone should have a pulse. And I was just cringing because it's not informed decision making at that point. But the EMT folks wanted to see it because those are their marching orders. And if where I live, the average age is old. It's like 75, and everyone wants to die in their garden on Orcas or Shaw, something like that. And so when EMT comes up, and most of them said, I don't want any of this heroic stuff, but that their only condition is they're 75 years old or something like that. And so they run into problems where they either don't have the pulse, and EMT shows up and does everything. And I've talked to grieving, surviving spouses that were like, that was the worst thing I've ever been through. But you couldn't go the other way. They didn't have a pulse because they weren't that sick before.
Right.
I have a pulse, and I'm not so good. But I have a pulse
Okay.
in my breathing.
Yeah.
On a quick note, as far as I understand it, I've had this situation with a patient where respiratory failure, they had a pulse filled out before they started declining. They didn't want to be intubated, but their children had power of attorney, and the children trumped the pulse. So in an event like that, we had to go off of what the children said in their decision in the hospital, not necessarily what the patient wanted, even though we knew that's what the patient wanted. And so it took some time to get them on board, but it's kind of a little...
Well, Two quick comments. First off, that's a great comment, thank you, because your durable power of attorney is the most important decision you make in this whole process. And also informing them, just as you said, about what your values are. Like, has it been a good, I want to stay alive no matter what, do everything. Or, you know what, it's been pretty good. If things get pretty tough, don't do anything. But you have to choose wisely. And you have to choose the person that's going to follow your decisions when you're not there. And it's not an easy choice. People don't do well with this.
And a big point, legal point, is if you don't do it, there's a statute that says who's got priority. And,
right.
You know, it does what they think most people would want to do, but a lot of times, you know, your spouse chooses if you have a spouse, if you don't have a spouse. Your kids, well, what if you got 4 kids of different religious persuasions?
Yep.
That can be a problem, and statutorily, they all equally have a say, and then you end up in some sort of standoff, and then the courts have to get involved.
Yeah. And it's those are some of the battles that I saw when I was in the hospital too, and you know, especially when you have, as you said, 3 or 4 kids, different views and the whole thing, or the kid that's been there taking care of them full time, and the 2 kids that come from the other side of the country who come once a year, and they kind of go, you can't let Dad go now. And you said, well, Dad doesn't want to do anything. Oh, that's not, no, we can't do that, right? As I mentioned, I was durable power attorney for my parents, and they were getting to be up there in years. So again, one of these discussions I had with them, my dad said, no, son, we don't want it, you know, no CPR, no machines, none of that. I said, okay, Dad, so if Mom collapses in the kitchen right now, it's gonna be okay. And he said, hell no, we're calling 911. And she didn't have a pulse for him, but it's like, it requires information and choosing the person that is strong enough under fire that they're going to stick to your guns that you want, the way you want things done. Just like the patient you mentioned. I mean, that person had every right not to be intubated.
Yeah.
Any other?
You guys these are amazing, great questions, and you're pointing to the sort of problem with all this, and that is that human life is incredibly complex, and no form is going to fix that. And I totally agree that those conversations that you have and people who support you and anyone who could possibly raise the red flag, whether it's your spouse or the caregiver or whatever, needs to be talked to over and over again about how important it is that your wishes be honored. And still, it's and we put 90% of our sweat and blood into those 5% of cases that don't fit the norm, you know, and that will never change with a form. But if we can become better informed, this is a great way to, you know, raise that bar.
I just wanted to say that we'll cover all of this on Thursday. So that's
I would love to make it.
Yeah.
Yeah.
Okay, so we're moving on from heart and lung stuff to problems with vasopressor drugs to support blood pressure. Excellent. Vasopressor drugs, as some of you know, are drugs that act like adrenaline. They increase blood pressure, the cardiac output, and pulse rate. They must be given through a central line because they're such intense vasoconstrictors that if we're given through a peripheral IV and it leaks, it'll cause necrosis of the skin around it. It's used to treat shock or critically low blood pressures. It increases blood flow to the vital organs, specifically the brain, and usually to the heart and to the central organs. That said, there's a lot of collateral damage that happens with these, especially when they're used in high doses for a long time. Again, these are intense vasoconstrictor drugs, and oftentimes in people that have severe septic shock, which is probably the most common, they'll be on a combination of norepinephrine, epinephrine, and vasopressin, and on the highest doses possible, and sometimes it's for 3 or 4 or 5 days. Well, when that happens, a lot of these little collateral blood vessels aren't going to do so well. Next slide, Bill. One of the things, again, this is an example of ischemic hands in an individual that was on large dose of pressors, where the blood flow to the skin and the hands because the digits are the ones that take the hit the first because they don't get enough blood flow because they're the smallest, and that's truly the collateral damage that the body is willing to sacrifice. Next slide. This is another example. This again is someone that was treated for septic shock and actually developed dry gangrene of their digits, and this is after they were surgically taken care of. Interestingly, many times they aren't surgically removed, and they kind of mummify and slowly just go back to somewhere between here and here, for example, and actually epithelialize and actually do much better than you would think. But that's, again, typically on very high doses for long periods of time. Vasopressor drugs, in the right place when someone's in septic shock, absolutely the right thing to do. If the patient's on them, again, multiple drugs for a long period of time, and you see that their circulation is not doing well in their feet, typically you go in, you say hi to your loved one or your patient, and you go, this isn't looking so good. Then you at least have to start raising the question of where you're going if their blood pressure hasn't begun to respond by that point. On circulatory assist device, we're going to talk about what we do in the circumstances of severe heart failure. Next slide, Bill, please, Bill. So for severe heart failure, we typically are using either medications like milrinone, which is a very short-term therapy and is only marginally effective. In fact, when people get it, they have to come in the hospital usually for 4 or 5 days at a time and get intravenous milrinone, go home and come back in a week later, come back a week later, and it just barely helps them limp along. There's also a device called an IntraAortic balloon pump, which is temporary and used for the specific purpose of improving coronary circulation in someone who has had a recent heart attack or percutaneous intervention or heart surgery. And then a left ventricular assist device, which can be either short-term or long-term. Next slide. So this is the intra-aortic balloon pump. It's inserted in the femoral artery down here and comes to a very complex device over here, and then goes up and is adjusted so it sits just below the arch of the aorta. And during systole, when the heart's contracting, the balloon completely deflates so that blood, as it's squeezed out of the heart, can go down and perfuse the organs below for the vessels that come off the aorta below there. And then as soon as it goes into diastole and the flow stops and the pressure starts going down, the balloon inflates for the specific purpose of forcing blood back and into the coronary arteries. Again, this is most often used in patients that have had open heart surgery and their muscle's not performing well, and they want to make sure it gets the maximum chance of the muscle surviving as best it can. Short term, again, if it's not working after a week, chances are it's not going to be a successful outcome. Next slide, Bill. And this is a left ventricular assist device. Theoretically, if someone had a severe heart attack and their heart muscle wasn't working, they had an intra-aortic balloon pump, which didn't help, they could receive a left ventricular assist device. This is a little pump. It's right here. And it actually takes blood out of the left ventricle through the pump and then puts it back into the aorta. And it's powered by an electrical device. This tells it how fast to go and measures resistance, and it's powered by batteries. The odd thing about these people is they don't have a pulse anymore. And when you listen to them, you don't hear lub-dub, lub-dub. You hear just a constant flow. And it's just kind of a bizarre thing when you're examining them. And you're taking their blood pressure, and there's like nothing there. They're talking to you, and you're kind of feeling it's like, because they no longer have pulsatile flow. They have continuous laminar flow all the time. And it's just pretty interesting. There was a left ventricular assist device program in Bellingham at St. Joe's for about 5 years. And I think during that time they did about 15 patients. The physicians who were doing it have since gone to Spokane, and it's no longer available. It was used, let's go to the next slide, we'll show you what it looks. This is kind of, by the way, what it looks like in real life. This is where it enters the skin, so it has to be protected. It typically was used in younger people. In fact, it was designed for young people who had an acute cardiac injury, like from a viral pericarditis or myocarditis, where the muscle was damaged, or postpartum cardiomyopathy where they develop severe heart failure and they can't survive so you put them on you put a left ventricular device in place until they can receive a heart transplant. Then it became like, oh, you know what? We can keep people going for 5 years this way. So then there are people that are in their later years who have severe heart disease from a heart attack, for example, and they get a left ventricular device as a destination. That is going to keep them alive until they something else comes along and intervenes. I know one gentleman in town that has had his for 7 years, and he's a well-known figure at the hospital. He comes in to visit patients all the time. He's actually a pretty incredible guy. These people must be absolutely meticulous about everything, because if you're not, it's not going to work. You let this get infected at the exit site, the game is over. You don't keep your batteries charged. You can't just plug it in. It's like you don't put it in your cigarette lighter and say, oh, I'm running low on juice on my phone, I think I'll plug it in. That doesn't work with these. So you have to have good redundancy and real compulsive behavior to do well with this. Next slide, please. The downside of the left ventricular assist devices are that they oftentimes end up with a 4 to 6 week stay in the ICU when they first are placed. You can just imagine your body, which has been used to pulsatile flow for all its being, is now having to get used to an entirely different way of dealing with circulation. Vascular injuries can occur where it's inserted into the aorta. Of course, if it's an older person with a severely damaged aorta, you can end up with cholesterol embolization. Infections is probably the biggest thing. This is a foreign device sitting in the body. If it gets infected, the game is over very quickly. They require anticoagulation so that the pump doesn't clot. If the pump clots, obviously, it's going to do one of two things. It's either going to cause emboli to be sent up to the brain or other organs, or the pump itself could just clot off and stop working. But with any anticoagulation, the possibility of bleeding is a problem. Kidney failure is really common because, again, the kidneys are not used to non-pulsatile flow, and they require a higher mean blood pressure than some of the other organs to do well. In younger people, it's not an issue, but in older people that have any sort of vascular disease or long-standing hypertension, it just does not tend to work out well. Next slide, please, Bill. Okay, now we'll talk briefly about dialysis and kidney replacement treatment. So most often, kidney replacement treatment or dialysis is required when the kidneys fail, which in the hospital under the acute setting is usually caused by shock, severe heart failure, as for example, severe myocardial infarction with big decrease in the ejection fraction, and now they're not perfusing their kidneys well. The intravenous dye that's used for procedures is damaging to kidneys, and there's a whole host of medications which can cause this. When the kidneys fail, fluids only leave the body by kidney function for the most part, other than a little bit by respiration and by sweating. Toxins build up from waste products, and you can also see significant electrolyte derangements, and consequently dialysis will be required. In the hospital, or acutely, anytime, I guess can be done in the outpatient setting as well, the patients will require a central dialysis catheter. It's a large bore catheter, probably about the size of a large pen, that is tunneled into the skin and then goes into the internal jugular vein, down the superior vena cava, and actually the tip of it rests in the right atrium. And then there's a cuff in here, which over time the skin will grow into and prevent it from being pulled out and prevent the outside world from getting in to some extent. And then when they hook up for dialysis, blood goes out of one port, the blood's cleaned and returns through the other. Next slide, please. And this is just a quick schematic of what dialysis looks like. We have blood coming out on the red or arterial side. Now this would be someone with chronic kidney failure or end-stage renal disease that has a fistula in their arm. Comes out of the arterial end of the fistula, goes up, goes through a filter, and on the outside of the filter is the dialysate, which comes in from the top, and it has a composition that we want the blood to look like in terms of electrolytes, and it does not have any waste products. And then as the blood goes through that, the waste products diffuse out and go in and are wasted. And then the clean blood is then returned in the blue line to the circulation. And this is kind of what it looks like. This fellow would be someone, and this is what the dialysis machines look like. As you can see, it's obviously much more complicated than this little schematic here. It constantly monitors the electrolyte concentration to make sure that it's proportioning things right. It measures the pressures closely in the blood flow going in and out of the arterial and the venous lines. Monitors for blood getting into the dialysate as well. Okay, next slide, please. Again, this is sort of the dramatic picture of what dialysis can look like in the ICU. Again, the patient's on a dialysis machine with a lot of other devices and really sick. Next slide, please. Okay, what are the complications of acute dialysis? Well, probably the one we worry about most, and always caution patients in the hospital when they tell them you have acute kidney failure and we think you need dialysis, is the biggest risk is that you may not recover, and you're going to end up on chronic dialysis. Generally speaking, in broad terms, if someone is perfectly healthy, comes in and has acute kidney failure, either from trauma or from medication, they've got about an 80 or 90% chance of having full recovery. As people get older, much beyond 60, and have each time you add a new medical thing, like add diabetes or add hypertension or add heart disease, you start knocking that down by 10%. So when you get someone that's 80 years old and they have heart failure and they have diabetes, and now you're talking about some neighborhood of about 20% chance of recovering.
If they need dialysis, would they recover without it? I mean...
No, they would die without it.
Okay. So
No. But what you're doing is you're telling them, well, these are the chances of getting off dialysis. And if they had pre-existing kidney disease, the chances are oftentimes...
You said complications of a failure to recover, and so I was wondering...
If they didn't...
An option.
I mean, yeah, it's like if a left ventricular assist device is only an option if you need it, right? Okay. So, I mean, it's the conversation you would have with them, saying, you know, just have to understand there's a good chance that if we do this, we'll get you through this part, but it's not going to be the end. Chances are you're going to end up being on dialysis. And again, depending upon the patient's other medical conditions and what they want out of life, they get to make that decision. And if they want it, that's what we do. But it is one of the things that can happen. Right? That catheter, which is a nice polyurethane catheter sitting in the bloodstream, has a high risk of infection. Or you can reach a point where it doesn't function well, and you're not able to dialyze them despite best intentions. They also get blood thinners, and hemorrhage can be a problem associated with that as well. And as you're removing fluid on dialysis, because remember, when their kidneys aren't working, every bit of fluid that goes into them, and when they're in the intensive care unit getting all of the drips, there's a lot of fluids going in, and you have to try to figure out how you can remove that without removing it so rapidly that they end up with hypotension or shock. Next slide. Okay. Sean, my understanding is the antibiotic question is not going to be there anymore. Is that true?
We're going to be making a recommendation, I believe, later this year that this whole section goes away.
Okay. Almost everybody that I counseled regarding pulse trauma kind of said, I don't know why you wouldn't want antibiotics. I mean, they kind of seem cheap and easy. I guess the one circumstance where antibiotics would make sense not to take them if you are truly in the last days of your life and you develop pneumonia. I wouldn't want antibiotics, and I would want nature to take its course and allow me to die a natural death, which would be the one circumstance. So I guess that's probably why it was there originally.
Yeah, and I think too that one of the things that's lost when you look at this is the differentiation between going to Rite Aid and getting Cipro pills for a UTI and taking them at home versus so sick that you'd be in the hospital because you have a severe illness and you're on IV antibiotics.
Right.
So sometimes we write in oral antibiotics only. But I don't want to go to the hospital anymore, so that's an option.
Okay. So then the next big question is medically assisted nutrition, which is something people usually feel pretty strongly about one way or the other. Next slide, please. Next slide, please. Okay, this slide kind of shows all the different types of nutrition you can get in the acute care setting. Most common is nasogastric tube, which goes from the stomach, nose, down to the stomach. Ideally, you take it further, either to the duodenum or actually ideally to the jejunum. And the reason is, again, if the feeding tube is in the stomach and you're getting tube feedings and your stomach's not working well because you're ill, you can again get a gastric distension and regurgitate and have aspiration. If the person is going to have it long term, it can go through the stomach wall, say a gastrostomy tube or a gastrojejunostomy tube. And then obviously they can get total parenteral nutrition intravenously for people who have had large intestinal procedures, for example, when it's likely that their gut is not going to work for a week or 10 days. That's the only way they're going to get adequate nutrition. But it comes with a cost. It can cause a lot of problems with electrolyte disorders and actually has an immunosuppressive effect. And then you can also short-term, like if your gut's not working just expectedly for a couple of days, you can get peripheral parenteral nutrition as well. This goes through a peripheral IV. It has lower concentrations of amino acids and sugar so that it doesn't destroy the veins while it's going in. So, okay, these are complications associated with enteral nutrition. There's those related to the tube where it can be malpositioned, displaced, blocked. I've actually seen problems where the tube, if it's a nasogastric tube, ends up eroding the corner of the nose, which can be very painful for patients, and obviously aspiration can occur. Diarrhea is extremely common because of the high concentration of nutrients in the tube feedings, bloating, vomiting, cramps. And then again, the biggest thing we worry about is, of course, electrolyte disorders. If the compositions aren't done right and they get diarrhea, now the person can get hypernatremic and hypokalemic. If the vitamins aren't adequately managed, we can see all sorts of deficiencies. And also, some of the tube feedings can actually adhere to medications. So here we are, I think we're going to switch this medicine from IV to PO, and suddenly their blood pressure goes up, and you go, why is this not working? Well, it may well be that the medicine is being absorbed by the tube feedings, and they're not getting any of it. Any questions about that? Okay. Okay, this is a bad example of a malplaced feeding tube. This is a tube that thought was to be in the right place, went down the trachea in a person who had a low level of consciousness and ended up in the right lower lobe and ended up getting some tube feeding there. This rarely happens nowadays. They actually have a device to follow the tube in. I don't know if you probably have seen those in the hospital. They can actually monitor it and make sure it goes to the right place. And this is the reason why we have those, so that those sorts of complications don't occur. And usually nothing goes in the tube until you get an X-ray and see where it is if you don't have, I don't know the name of the device that follows it, but critically important. Okay, so those are kind of a look at all the intervention, all the things we can do to make bodies live longer. But we can also reach a point where we might say, you know what, I don't want that to be my primary focus anymore. And then we start talking about comfort-focused care. Next slide, Bill. And here we're talking basically about palliative care and hospice care, which are sort of a overcrossing specialties of care for people who have serious illnesses. Next slide, please. Palliative care is somewhat new, probably in last 10 to 15 years relative to medicine as a whole. It is a specialized, a specialty of medical care for people who are seriously ill. It's focused on relieving suffering for people of any age, of any stage of serious illness, whether it's curable, chronic, or life-threatening. And the goal of it is to improve the quality of life for both the patient and the family. Next slide. This is a slide I really like. This kind of shows how the course of an illness goes. Remember, you gave that example before of here I am and I get a lymphoma and I start treatment. So I'm over on this time zero portion of this curve. So here I'm going to initially have 100% of my focus on curative care. So I'm going to be getting chemotherapy and whatever drugs or radiation therapy it takes to get better. And as time goes by, and I may actually seek palliative care during that time as well to make sure I can help me deal with the illness and facing the fact that I have a potentially fatal illness. As time goes by, and now it appears that I'm not doing so well, and I do have a recurrence after 6 cycles, and I kind of go, I don't think I want to do this anymore. Now I'm really moving more and more toward palliative care and perhaps out of the curative care range entirely. And now I'm going to rely more and more on palliative care as I get to this point. And finally I'm going to say, you know what, I don't want to go back to the hospital. I don't want any more curative treatment. I want hospice care. And I want to be comfortable, and I want to die at home, or I want to die in hospice house. And then as we get to the point where I leave the picture, then there's death and bereavement care for my loved ones. Next slide, please, Bill. Benefits of palliative care. There are very good studies which show that these benefits are seen without reduced survival in patients getting palliative care. They have better pain control, less distress with their illness. They have improved health-related quality of life scores. They have high patient and family satisfactions with their care. There's an increased likelihood that they will die outside the hospital. And there's a reduction in hospital and ICU lengths of stay. In my particular specialty, in end-stage renal disease, there are very good studies that the frail elderly that don't choose dialysis actually live longer and don't go in the hospital as often. And there's also pretty good examples of certain types of cancer when they reach a point where they will actually do better staying out of the hospital and do just as well. Next slide, please, Bill. And this is a comparison of palliative care and hospice care. Both are focused on aggressive pain, symptom, and quality of life management. With palliative care, the patient has a serious or chronic or life-threatening or life-limiting illness. Under hospice care, the patient has a terminal illness which is no longer treatable and is expected to have fewer than 6 months to live under the normal course of the disease. Care philosophy centers for both of these disciplines centers on a team approach that includes the patient, family, and the primary care providers. Same. For palliative care, the patient may be seeking curative treatments and may return to the hospital. With hospice care, the patient is no longer seeking curative measures and will not return to the hospital for treatment. Any questions about those? Because it seems to me that's another one of those areas in medicine which kind of gets blurred with people, like as in palliative care, the same thing as hospice care, and the answer is it really isn't at all. It's a whole different, it's really focusing on the patient and how they are dealing with their illness and making sure they're comfortable and they get good pain control. Tom, do you have anything to add about that? Yeah. Anybody else? Questions? Yeah.
Has it changed much recently with respect to aggressive pain management with the whole, opiates? And I remember years ago there was kind of a move that way, and all of a sudden people who had horrible diseases and incredible pain couldn't get the pain management. I was curious whether that's been an issue.
I mean, I think that, and I meet with a lot of clinicians who are actively doing palliative care a lot. I do it as a relief person now. It certainly complicates the world where people are depending on their primary care doctors to fill those scripts. They're looking more and more to palliative care. I think actually that doctors who are working in specialties and in just primary care are looking more and more to palliative care people. If someone has a serious illness that's going to be kind of ongoing and pain is going to be an issue, those palliative care people have that sort of go-ahead from the state to be able to oversee a long-term management for pain medicines that is less supported in primary care now because there are so many restrictions on it with the opiate crisis. Does that help?
Yeah, exactly.
Yeah,
Thank you.
there's kind of a carve-out for people who are on palliative care and certainly for people who are on hospice care. But it's a tricky thing, and it has caused some problems,
I recently read something about that same problem of kind of the rebound of like now it's more difficult to get good pain control again, except when you get good palliative care and hospice care folks taking care of it.
I know someone who just had really painful surgery and had to go back and get their pain medication renewed. And there was some issue. They had to prove actually that they'd taken the medicine because they were afraid they were selling it in the black market.
Absolutely.
This is bizarre.
Any other questions or comments about palliative care, hospice care? Okay, we're getting to the end here. Things I'd like you to remember from today. Everyone over the age of 18 should have an advanced directive. Those who have a serious illness, heart failure, respiratory failure, kidney failure, malignancy, or severe neurologic disease should also have a pulse form. Or if you could also add frailty there. I think we all have had in our families elders who don't have a clearly defined illness, but you know if they fell, it was going to be like an egg be like Humpty Dumpty. Have the discussion with your family or doctor. It is a shared responsibility. But it must start with us. We also need to know the realities of the care we want, and there's no sense delaying it. It always seems too soon until it's too late, so let's start now. Next slide, Bill. So it starts with a conversation with yourself. Think about what you value in life. Think about what are the things you would want, what care you would want when you are in the circumstance of being critically ill and can't speak for yourself. Discuss that with your loved ones. Choose the person who will speak for you when you can't communicate for yourself. Attend the advanced care workshop to help complete your advanced directive. And when you have it in hand, keep a copy for yourself, to your spokesperson, and also with your healthcare providers, including the hospital and your doctor. Okay? Oh, that's the wrong slide. Go forward 3 more. Oh, stop here. We're all in this together, folks, so let's make sure we help each other get there. And now go down 2 more. Okay, so 3:30 on the 12th here, Dr. Bill Chow, as a certified advanced care planning facilitator, will guide you through filling out your advanced directive. Okay, any questions?
I just like a quick one. I guess nurse to provider. If I feel like maybe the family's not having a hard time like getting grips with that sort of thing. Like I mean, I've put in, and this is like no dig on providers or anything, but like put in like, hey, they need a palliative care consult, or I feel like the family and the patient's really worried about this. Like what we're doing is a lot, and I don't know if they're necessarily getting a quality of life with this. But not seeing anything come from it. What's the best way? Like in your opinion, for me to approach you and say, hey doc, like they needed a consult, like is that just the best way for me to say that? Like how do I ensure that gets a follow-up?
I think actually, from the nursing point of view, it's very helpful to have that conversation with the physician. And I can't think of anyone nowadays who would not respect that. Sometimes it's just to help the family get clear on what their goals of care are, And I don't think there's too many people now who don't get palliative care consults in the hospital. It's a really busy service, but it really should be this is a team effort. Nurses play a critical role in how patients get their care, and as far as I'm concerned, they were my go-to people in the hospital always. I couldn't have done my job without good nursing care. That's for sure. Thanks so much, everybody. Appreciate your attention. Yep.